Vanakkam. Imagine a muscle A, and when it contracts, it produces an action X on a particular joint. If every muscle on the hand was as simple as that, we would never have the complex movements that we can see either at work or in art. Now just see the fingers of this man playing the piano. The fingers are just gliding over the keys of the piano, and every single movement, every single joint of the hand is giving back a signal to the brain saying that it is in this position, and the brain gives back a signal to the muscles acting on that joint, asking them to contract at this level or at this level. Or imagine the power that is being transmitted into this hand to get the work done. All are being done by the same muscles in the hand. So, is it difficult to understand these complex movements that are occurring in the hand? Definitely not, especially if we are going to deal with it in the way that it is going to be dealt with in this video, because we are going to see 3 extensor muscles acting on the wrist, 3 extensor muscles acting on the thumb, 3 extensor muscles acting on the fingers, and 3 salient features of each of these muscles with regard to biomechanics. The agenda for this session is that we are going to see the muscles causing extensor wrist movements, extensor thumb movements, and extensor finger movements. First, we shall see the extensor wrist movements, and the muscles acting on the wrist causing extension are the extensor carpi radialis longus, extensor carpi radialis brevis, and the extensor carpi ulnaris. We shall see 3 important biomechanical characteristics of each of these 3 muscles. First, the extensor carpi radialis longus, or the ECRL, which originates from the lower 5 centimeters of the humerus and inserts into the dorsum of the base of second metacarpal bone. The first important salient feature of this muscle is that though it is touted as an extensor of the wrist, it has got 2 other important function capabilities. It can also act causing flexion of the elbow owing to its 5 centimeter origin from the lower end of the humerus, and it also causes radial deviation of the wrist owing to its insertion on the radial aspect, that is the base of the second metacarpal. This radial deviation can be countered only by the extensor carpi ulnaris, and the elbow flexion effect can be negated by fully extending the elbow. The second important point is that it is an indicator of return of function after radial nerve injury or reconstruction, because it is the first muscle to be innervated from the radial nerve after it exits from the spiral groove, and secondly, the innervation of this muscle can be easily identified by the radial deviation and extension of the wrist. And thirdly, we need to remember that it can be well used for any tendon transfer because it has a long tendon, it can be replaced, and it is easy to re-educate. So it is used in procedures like EF40 procedure or reconstruction of flexor digitorum profundus of the fingers. Next, we shall see the features of the extensor carpi radialis brevis, the ECRB, which arises from the lateral epicondyle and inserted into the base of the third metacarpal bone. The most important thing to remember about the ECRB is that though it is smaller in mass than the ECRL, it is a more effective wrist extensor because it has a larger tension fraction than the ECRL, meaning more power. It has a larger momentum for wrist extension, so it is very easily a wrist extensor. It has a smaller momentum for radial deviation, so the power is not lost by radially deviating the wrist, and the whole muscle is available for wrist movement, unlike the ECRL where some of the movement is lost in elbow flexion. Not only does the ECRB have a higher power, the second point is that it has a higher excursion potential, and only half of this excursion is used for wrist extension. We can understand this better by looking at the anatomy of the muscle fibers of ECRB. The length of the muscle fibers is around 6.1 centimeters, and we know that the potential excursion of any muscle is equal to the length of the fibers. So the potential excursion of the ECRB is 6.1 centimeters, but the actual excursion needed for wrist extension is only 3.5 centimeters. So you can even transfer the muscle to perform a function with more excursion, like for instance the finger flexors. But there is a caveat here, and that is the third important point of biomechanical significance of the ECRB. The ECRB muscle should rarely be used for transfer, however, because it is the key extensor of the wrist. But if it is to be used, there are three important criteria that should be followed. The tendon should continue on the dorsal side, the tendon should remain in the sheath, and the distal action that is going to be performed by the transfer should be synergistic with wrist extension. Under these criteria, the extensor carpi radialis brevis can be used for transfer. Now we shall see the extensor carpi ulnaris, the ECU which is inserted on the base of the fifth metacarpal. The first point we need to remember about the extensor carpi ulnaris is that it is a long muscle, almost 21 centimeters, with rather short fibers of around 4.5 centimeters length only, and this muscle is present in a tight facial compartment. The second important point to remember is the constant relationship of the distal tendon of the ECU with the head of the ulna. Here you can see in the supine position of the forearm, the ECRL tendon and the ECU tendon both lie on the extensor side of the flexor extensor axis of the wrist. However, in mid-prone position, the radius, when it rotates around the ulna, the ECU continues to stay with the ulna, but all the other tendons move. So now the ECRL is still on the extensor side of the flexor extensor axis, but the ECU is now almost on the flexor side of the flexion extension axis of the wrist. So in mid-prone position of the wrist or completely pronated wrist, the extensor carpi ulnaris will not function as an extensor. Only the ECRL will continue to perform the function of extension. To elucidate this point further, I shall demonstrate this movement on my wrist. In completely supinated forearm, both the ECRL and the ECU will be extensors of the wrist. But when the forearm goes into prone position, the radius has rotated around the ulna, so only the extensor carpi radialis longus will continue to extend the wrist, while the extensor carpi ulnaris will not act as an extensor in this position. The message is that due to the constant relationship of the distal tendon of the ECU with the head of the ulna, the extensor carpi ulnaris is an effective wrist extensor only in supination and may not be an extensor at all when the forearm is pronated, but it will continue to be a strong ulnar deviator either in pronation or supination. This relationship of the tendon of the ECU is very important because it stabilizes the head of the ulna. The third significant biomechanical feature of the ECU is that it can be used as a tendon transfer, like for example for opponentsplasty, but we need to be careful when using this tendon for transfer in conditions like rheumatoid problems because it may lead to instability of the distal ulna. With that, we have finished discussing the salient features of the muscles causing extensor wrist movements. Now we shall consider the extensor thumb movements. The extensor muscles acting on the thumb are the abductor pollicis longus, the extensor pollicis brevis, and the extensor pollicis longus. The abductor pollicis longus or the APL, one of the deep muscles on the extensor aspect of the forearm, is inserted into the base of the radial side of the first metacarpal. The first important feature of the abductor pollicis longus is its varied function on different joints. It serves as a radial abductor or extensor of the thumb, an abductor and flexor of the wrist, and it maintains the arch of the pinch by countering the adductors which are pulling the thumb from the ulnar side and it also stabilizes the carpometacarpal joint to allow flexion of the metacarpophalangeal joint by the flexor pollicis brevis or the adductors. Please click the icon above to see the detailed anatomy of this part of the muscle. The abductor pollicis longus is a radial abductor, as we have seen, and not a palmar abductor like the abductor pollicis brevis. But when the abductor pollicis brevis is paralyzed in a case of median nerve palsy, there is a trick movement by the abductor pollicis longus where bowstringing occurs by flexion of the wrist, and there is an attempt at palmar abduction, and this trick movement is carried out by the abductor pollicis longus. The third point to remember is that the tendon of the APL is often multi-stranded and sometimes it has more than one insertion. We can use the strands for transfer conditionally, that is, if the strands are continuous with a portion of the muscle and not with the entire muscle. The extensor pollicis brevis muscle inserted into the dorsum of the proximal phalanx of the thumb is closely associated with the abductor pollicis longus. It has similar actions at the wrist and CMC joint, but it is smaller and weaker than the APL. But the primary action of this muscle is as an extensor of the metacarpophalangeal joint of the thumb. If this independent extension of the metacarpophalangeal joint is lost in paralysis, it is not necessary to replace it, as a good extensor pollicis longus will extend both the metacarpophalangeal and interphalangeal joints of the thumb. Since it is not such an important muscle, this tendon can be used as a tendon graft, but usually it is not advised to sacrifice any motor to the thumb, however weak or insignificant. The extensor pollicis longus is another deep muscle from the extensor aspect of the forearm, inserting onto the dorsum of the terminal phalanx of the thumb. The course of the extensor pollicis longus tendon from the Lister's tubercle to the thumb is very interesting biomechanically. It runs towards the metacarpophalangeal joint and crosses the metacarpophalangeal joint on the lateral aspect of the dorsum, and then goes on to the middle of the back of the terminal phalanx where it gets inserted. This anatomical feature is reflected in the functions of the EPL at different joints. At the IP joint, it is an extensor. At the metacarpophalangeal joint of the thumb, it is again an extensor. At the carpometacarpal joint of the thumb, it is an adductor, extensor and supinator, and at the wrist, it is an extensor and radial deviator. In the normal hand, the EPL is mainly an extensor of the phalanges and pulls the whole thumb back, for instance for clapping, slapping, pushing or holding up traffic. Apart from all these functions, there is a very interesting function taken up by the EPL in certain conditions. When the median nerve or ulnar nerve is paralyzed, the extensor pollicis longus takes on a new function and causes what is known as a lateral squeeze. In such conditions, the FPL and the EPL sometimes become the only muscles acting on the thumb. When this happens, both these muscles act on all the joints of the thumb, and the resultant movement that occurs depends on which is more powerful in terms of which has got a more favorable moment arm. So what we find is flexion at the interphalangeal joint and flexion at the metacarpophalangeal joint owing to the more powerful FPL on these two joints, and extension and adduction at the CMC joint owing to the more powerful extensor pollicis longus on this joint. So this is the lateral squeeze that occurs. Flexion at the IP joint, flexion at the MCP joint, and adduction and extension at the CMC joint, giving some sort of prehension to this paralyzed thumb. Having seen the extensor wrist movements and the extensor thumb movements, we shall now see the finer aspects of the finger movements that occur not only on the extensor side but also the flexor side. The extensor muscles acting on the fingers are the extensor digitorum communis, the lumbricals and the interossei. And when we consider the extensor digitorum to the fingers, we shall also be considering the extensor indicis proprius, the extensor digiti minimi, the extensor digitorum communis proper to the index, middle, ring and little fingers. The extensor indicis proprius is a deep muscle and the tendon travels on the ulnar side of the tendon of the EDC to the index finger on the dorsum of the hand. The first characteristic feature of the EIP is that it is sometimes known as a pointing muscle, as it allows independent index finger extension with the rest of the fist clenched. This muscle is a constant muscle but pretty weak. The second important point to remember about the EIP is that it is a commonly used muscle for transfer. But when this transfer is done, patients should be warned about loss of independent index finger extension or a lag that develops in the index finger. And to prevent this problem, the extensor hood must be well repaired after harvesting the tendon, and the EDC tendon to the index finger must be centralized. And more importantly, when we are planning to use this tendon as a transfer, we need to remember that it is a weak muscle. So it is good for solving positioning problems like clawed fingers or thumb opposition. But it is not strong enough to compensate for lack of real power, as in finger flexion or thumb adduction, or even to replace the first dorsal interosseous. Just like the extensor indicis proprius being an extra extensor muscle to the index finger, the extensor digiti minimi is an extra extensor muscle to the little finger. But there are a few differences. This muscle has two tendon slips that run over the dorsum of the hand toward the metacarpophalangeal joint of the little finger. Though it provides independent extension of the little finger, it differs from the EIP in that here it is the main extensor of the metacarpophalangeal joint of the little finger, because the contribution from the extensor digitorum communis to the little finger is very inadequate and cannot extend the little finger by itself sometimes, and it is obliquely oriented, looking more like a junctura than a tendon. So in any situation, if the extensor digiti minimi is used as a tendon transfer, then there will be quite a gross lag in extension of the little finger. So we need to replace this with a slip from the ring finger EDC. Now we shall consider the extensor digitorum communis proper to the index, middle, ring and little fingers. The first point to remember is that the EDC is a weak muscle. The FDS and FDP of the middle finger alone are together as strong as all the extensors to all the four fingers. The second important biomechanical feature of the EDC is the juncturae tendinae. These achieve force distribution to dynamically stabilize the metacarpophalangeal joints of the fingers. Let us see how this is done. In a power grip, when a fist is made, there are two opposing force systems coming into play. One force pushes the metacarpal heads apart in radial and ulnar directions, and a counter force collapses the metacarpal head towards each other. So dynamic stabilization of the metacarpophalangeal joints is achieved by the juncturae tendinae. The second important point about the extensor digitorum communis is that the primary action of the EDC is extension at the metacarpophalangeal joint of the finger. Now we shall consider the four lumbrical muscles, of which the first and second, that is to the index and mid finger, are supplied by the median nerve, and the bipinnate muscles for the ring and little fingers supplied by the ulnar nerve. And all these muscles are on the radial side of the finger and attached to the dorsal extensor apparatus on the radial side. The lumbrical muscles have unusual biomechanical features, and the first involves the anatomy and the excursion of the muscle. As you may be aware, the lumbrical originates from the flexor digitorum profundus tendon and is inserted into the lateral band on the dorsal extensor apparatus. This origin and insertion takes up about 1.5 centimeters of the muscle, leaving behind the middle 3 to 4 centimeters as a cylindrical muscle with parallel fibers. Now the excursion of the lumbrical is also unique because both the origin and the insertion are mobile. The excursion of the origin is about 3.5 centimeters and the excursion of the insertion is about 1.75 centimeters. The gross excursion of this muscle is around 2.75 centimeters. The second important point is that the lumbrical muscles are special in another way. They have the largest density of spindle cells, like for instance the masseter muscle, the extraocular muscles or the tongue muscles. This makes them very sensitive to changes that are occurring in the joint level. And as far as the function of the lumbrical muscle is concerned, it is mainly at the interphalangeal joints level and not the metacarpophalangeal joint level. Now we shall see the common features of the interossei muscles, both the dorsal and palmar interossei. The first important unique feature of the interossei is that they are all short fibered muscles that have long tendons of insertion. So they have a short excursion, that is only 1/4 of the excursion of the lumbricals, but they can exert 4 times as much tension as the lumbricals. So we can say the interossei muscles are short powerhouses. In fact, they are as strong as the FDS of the finger with only about 1/4 of the potential excursion. So what do these powerful muscles do? Most importantly, they are metacarpophalangeal joint flexors and stabilizers. The orientation of the interossei muscles with respect to the joint axis of the metacarpophalangeal joint is that they have both short and long moment arms. The long moment arms make them good flexors. So a part of the interossei makes them act as primary metacarpophalangeal joint flexors. And not only that, the part of the muscle with the short moment arm makes them a good stabilizer of the metacarpophalangeal joint so that the other muscles can act well on the finger joints. Before we go any further into understanding the interossei, let us consolidate what we have learned so far about the function of the EDC, the lumbricals and the interossei. This is the basic skeletal structure of the fingers of the hand, beginning with the metacarpals. This shows the extensor digitorum communis tendon, and this shows the volar plate of the metacarpophalangeal joint, and the sagittal fibers that come down from the EDC to get inserted on the volar plate. It is through these sagittal fibers that the EDC extends the metacarpophalangeal joint. Now you can see the interossei muscles and the tendon of the interosseus and the 2 types of fibers arising from the interosseous tendon, the transverse fibers and the oblique fibers getting attached to the fibers coming from the corresponding side. This shows the lumbricals and the insertion into the lateral band, and the flexor digitorum tendons are shown as the blue line. When the metacarpophalangeal joint of the finger is extended, the interosseous muscle's primary function would be extension of the PIP joint via the oblique fibers, and the secondary function of the interossei would be extension of the distal interphalangeal joint via the lateral band. But when the metacarpophalangeal joint is flexed, the primary function of the interossei would be metacarpophalangeal joint flexion via the transverse fibers, and the secondary function would be extension of the PIP joint via the oblique fibers. Now these interosseous muscles can cause 2 biomechanical problems: the intrinsic plus deformity and the intrinsic minus deformity. The intrinsic plus deformity is caused either by actual overaction of the interossei or spasticity of the intrinsics. Increased moment arm causes more flexion at the metacarpophalangeal joint and hyperextension at the proximal interphalangeal joint, otherwise known as the swan neck deformity. When there is a paralysis of the intrinsics including the interossei muscles, a claw hand develops. The characteristic features of weakness of grasp, even if it is only a low ulnar palsy, are due to the biomechanical disturbances that have occurred. This weakness is due to the loss of metacarpophalangeal joint flexion. So there is a loss of grip strength following paralysis of the intrinsics. Second, there is a loss of metacarpophalangeal joint stabilization. So what happens is the long extensor muscles become the stabilizers, and this weakens the flexor action, and the sense of instability of the metacarpophalangeal joint results in a weaker flexor action. So far we have seen the action of individual muscles on the respective joints. Now let us consider the movements from the aspect of the joints. With respect to the metacarpophalangeal joint, there are movements on 2 axes. One is flexion extension and the second is rotation, adduction and abduction. At the PIP joint there are only flexion and extension, and at the level of the distal interphalangeal joint too, only flexion and extension are present. As far as flexion and extension of the metacarpophalangeal joint are concerned, extension is caused by the extensor digitorum communis and of course the EIP and EDM as we have seen through the sagittal band. The intrinsic check rein prevents hyperextension. Flexion is caused primarily by the interossei, less by the lumbricals and least by the FDS and FDP, which can act only after a tenodesis of the PIP and DIP joints. Now we can consider the other movements occurring at the metacarpophalangeal joint, that is rotation, adduction and abduction. These occur mainly when the metacarpophalangeal joint is in an extended position. The rotation occurs by both the palmar and dorsal interossei acting alternatively. The adduction occurs mainly by the palmar interossei and the abduction occurs by the dorsal interossei. When the metacarpophalangeal joint is in a flexed position, there is no rotation or adduction or abduction. Now we shall consider the same type of movement grid for PIP joint extension. There are muscles that extend the PIP joint primarily and there are some muscles that extend it secondarily. With the metacarpophalangeal joint extended, the primary action of extension of the PIP joint is shared by the interossei and the lumbricals, whereas the secondary action is by the fibers of the EDC that have contributed to the extensor apparatus. When the metacarpophalangeal joint is flexed, it is the lumbricals that takes over because the interossei are primarily involved with metacarpophalangeal joint flexion. But secondary action is by the interossei and the fibers of the extensor digitorum communis. When the distal interphalangeal joint extension is concerned, the primary action is by the lumbricals via the conjoined lateral band and the secondary action is by the interossei and the extensor digitorum communis. Having seen all the movements at the metacarpophalangeal joints and the interphalangeal joints, shall we now consolidate all these to try to understand this better? The metacarpophalangeal joint extension is by the extensor digitorum communis. The metacarpophalangeal joint flexion is mainly by the interossei and less by the lumbricals and least by the FDS and FDP. As far as the interphalangeal joints are concerned, the extension is equally by the lumbricals and interossei and a contribution from the fibers of the EDC, and the flexion of course is by the FDS and FDP only. So considering this in a more simple and diagrammatic way to remember better, extension of the MCP joint by the EDC, flexion of the metacarpophalangeal joint by the interossei, lumbricals and rarely by the FDS FDP, extension of the PIP joint by the interossei and lumbricals and segment of the EDC and flexion by the FDS and FDP, DIP joint extension by the lumbricals, interossei and EDC and flexion by the FDP. Now we should have understood how each joint of the finger moves. Let us do a final test to confirm this. Which muscle is active in which positions? In full extended position of the finger, the EDC is extending the MCP joint, the interossei and lumbricals are extending the IP joints, the FDP and FDS are not acting. In a fully flexed finger, obviously the EDC is not acting, but the interossei are flexing the metacarpophalangeal joint. Lumbricals are not acting because the interphalangeal joints are not in extended position, but the FDP and FDS are acting to flex the IP joints. And in this position, sometimes called the intrinsic plus position, obviously the EDC is not acting, the interossei are acting, lumbricals are also acting to extend the IP joints, FDS and FDP are not acting because the IP joints are straight. So what happens in this hook grip as it's called? The EDC is acting, the interossei and lumbricals are not acting, but the FDP and FDS are acting. So now we have seen the basics of extensor wrist movements, extensor thumb movements and extensor finger movements. I hope you liked the video. I enjoyed making it. Do click on the shown links to see more about the detailed anatomy of the extensors of the forearm and hand and the dorsal expansion of the hand. and do not forget to subscribe to stay connected with the latest in learning hand surgery. Vanakkam.